actually has been also indicated in the pseudomembranous colitis. So this can cause it as well. CNS effects, there have been hypersensitivity reactions, photosensitivity, and weirdness. It has been actually associated with ruptures of the tendons, and pregnancy and nursing, it is contraindicated. Okay, breathe. You need to stand up? Yeah? Go ahead, stand up for 2 minutes, go ahead. You guys, you're just not taking it in anymore. I'm doing the peanut thing. Wah, 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 wah. Okay. 2 minutes. Right? You guys have all seen the peanuts. Wah, wah, wah. The teacher stands up there, and the teacher's talking. You ever hear the teacher in front of us talking in peanuts? Did you know that? Yeah. Watch an old peanut thing. And when the teacher talks, they go, wah, 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 wah. And that's what we sound like. Now we'll get into TB. Oh. Are you shaking it out? All right. Let's talk about another delicious infection here, right? This is so yummy. So we're not eating during this thing. Imagine going, being like someone who, is into was it micro, attending like a, well, I don't know, we talk about gross stuff we eat all the time in dentistry too. All right, back to work. TB. We all know about TB. We all have to be tested for it before we come into the program, right, into the university. It's a chronic disease and it's caused by a bacterium, Mycobacterium tuberculosis. Treatment of this disease, as we know, is insidious and difficult. It's very, very strong. And it's difficult because a lot of people do not have adequate defense mechanisms against the TB virus, okay? It's very, very strong. We have developed resistant strains because it's so pervasive, especially there are whole cultures and countries where it's completely pervasive through their environment. The drugs available are not bactericidal because they would be too toxic. So in treating it, have you ever known anyone to be treated or given prevention for TB? It's over a long period of time, and therefore their compliance is terrible, okay? So people are not really compliant about doing it for that long period of time. They don't take it as prescribed. So it has become an insidious, difficult infection that has spread through many, many cultures. It's rapidly spread, and it requires a drug regimen of between 9 and 12 months. We do know now there are multi-drug resistant tuberculi, okay? And this is increased by the spread through patients with HIV who are immunocompromised and also among large homeless populations. So it's kind of happened to the worst, and really perpetuated terrible things among the most susceptible populations, which is awful. Drug regimens are actually prescribed for people that are only at risk or have been exposed to the disease because of that in a preventive way. And people who receive a vaccine for it, if they go to get tested, always test positive. So if we have to assure that they don't have it, they wind up having to have an occasional chest x-ray. So this is something that many of you may have heard of or been familiar with or even been through yourself. We are in a university that is extremely multicultural, people from all over the world. So this is actually a huge, I hate to call it a problem within UB, but something that we're up against all the time in keeping everyone healthy. So this is something we run into all the time. You'll have to do it. Now, there is this almost has its own little cocktail, kind of like we were talking about HIV, in treating this disease. They're usually given a combination of drugs concurrently, and those would be isoniazid, rifampin, and pyrazinamide. And yes, you do need to know these, okay? These are usually administered concurrently from 9 to 12 months, and the pyrazinamide for the first 2 months. You do need to know this regimen. Ethambutol, if we have bacteria that are resistant to the other drugs, they may be given ethambutol as well. If the patient is compliant and the organisms are susceptible, the person does continue to take it, but they would be considered non-infective in 2 or 3 months. So if you have a patient who is honest enough to report a recent diagnosis of tuberculosis that has been put on the drug, okay, we have to look at how long they've been taking it, and we might have to have them be tested before they can be treated because it is so rapidly spread. So the isoniazid, this particular one, is bactericidal only against the actively growing bacteria where these cells are dividing. Okay, so we want to hit this early. 300 milligrams are given daily, and the CDC guidelines state that isoniazid can be given by itself for people that have been at risk for TB or have been exposed to TB. So maybe a family member, somebody that you live with or you've been exposed to for a period of time. Or if someone is immunosuppressed, they may be given this drug if they are considered at risk for it. If someone has active TB, we delay their dental treatment until they're cleared, and we have had to do this in our clinic, again, because of our population. We want to treat people, we want them to come back, we want to keep in touch with them, but we also don't want to spread infection as well. We don't want to put them or ourselves at risk. There are adverse reactions. Again, we've got the risk-benefit going there. 20%, that's huge, have a CNS reaction, and they think that's because it depletes vitamin B6. So what do? Give people B6. So often people are put on supplements along with this. Hepatotoxicity can happen 1%, doesn't seem like a big percent, but it actually is. They may exhibit clinical hepatitis. In 10%, when they go for laboratory values, renal and, the liver values, they will show high values within their liver. So that can happen. Okay, rifampin is one of the other drugs, number 2, used in combination with the previous drug that we talked about. And you also see it used for people that carry meningococcal meningitis. Haemophilus influenzae is the H. influenzae is the identified bacteria there. GI effects can happen, stomach distress with this. It also, we don't prescribe this, but the doctor will tell the patient they think that they have a bloody urine, but it actually turns bodily fluids an orange-red color. So something important to tell patients. Pyrazinamide is the third one. It's actually related almost to one of the B vitamins called nicotinamide, niacin B3. It is, again, given in this same kind of cocktail of drugs. It can be hepatotoxic as well. It can produce rash, hyperuricemia, so peeing a lot, and GI disturbances. The CDC recommends pyrazinamide for use during the first 2 months. Remember, with those other drugs, with INH, the isoniazid, and the rifampin to treat tuberculosis. And that's it. It's kind of a neat package of treating this disease, but really important for us to uphold our principles of helping our patients that are on these medications to comply with them. So we know someone's been on it, maybe they're no longer infected, they come in for treatment. Are you still taking your medication? Telling them the importance of continuing with it, because it's very easy, especially once people are feeling better or if they've been cleared, to stop taking a drug, especially when we see some of those negative effects. That's the most common reason people stop drugs, okay? They're having negative side effects and they stop taking them. We're going to talk just a little bit about topical antibiotics. They actually are fairly discouraged because the possibility of hypersensitivity is there. Of course, they should not be used systemically, so sometimes they are put in a topical format. Systemic is mostly going to clear things up the most. We, of course, all know about Neosporin, right? We all have a little tube of it in our medicine cabinet for when we need it. It affects gram-negatives microorganisms. It's a mixture of polymycin and bacitracin. And it should be used for surface only. So it's kind of the one you put a little blob of it when somebody scraped themselves on the surface there. Kind of what we call a deep cut there, but by relative standards, we put a Band-Aid on, we put a little bit of that on. If that wound then or is infected at that time, people should be treated systemically, okay? Even though we discourage a lot of use of antibiotics, the Neosporin polymyxin mixture is not going to do it. But we do mention it because it's pretty common. Another one is Bactroban, you've probably heard, Eupirocin. And this is for impetigo, it's used, and it's also used for angular colitis. I don't know if you could tell, that's the corner of someone's mouth there. Usually, speaking, it's actually a fungal infection that happens, and we see it with people that have kind of that decreased vertical thing here with often people with dentures, and they get that constant moisture around the corners of their mouth, and they wind up with a fungal infection, and if it doesn't go away or it's not treated with an antifungal agent, then they might wind up with a superimposed bacterial infection, and they would be given this drug for that. And that's it with those. Okay, let's talk a little bit about antibiotic prophylaxis. We're almost done here. It's used for preventive infective endocarditis, prevention of infective endocarditis, sometimes for dental procedures. Often these people have cardiac conditions, that's why they're given them. And we also might be using them for prosthetic joint prophylaxis as well. And we do this a lot less often for a lot less time than we used to. When I started in dentistry, people were taking antibiotics for 2 days before, the day of the appointment, and a day after, like several times a day. It was major, and now it's usually a loading dose, and we're done, okay? And you've already talked about this with Ms. Williams, so it's going to be a quick review. We know that infective endocarditis infects the heart valves and the endocardium of people. It can actually be fatal. It causes any introduction of bacteria into the bloodstream causes a bacteremia. We have someone with a significant dental infection and they have significant cardiac disease of certain types. They may be given this ahead of time, a loading dose to get the drug into the blood to fight off any possible infection. So we have to look at a few factors. The specific dental procedure that we're doing, how invasive is it? What is the cardiac or medical condition the person has? What is the risk with that based on evidence, not on fear? And the drug or the dose that may be needed. When this was first prescribed, it was prescribed out of fear. This person has a heart problem, they have rheumatic fever, they have a mitral valve prolapse. It used to be prescribed for everything, anyone even with an innocent heart murmur. They were given drugs for a multiple period of days, and the risk of taking the drug was much worse than the risk of developing an infection, and it wasn't based on any science, it wasn't based on any evidence from studies, it was based on fear. So now we know when to use it, and we use it discriminately. Dental procedures that involve the manipulation of gingival tissue or the periapical region of the teeth, okay, in most cases, no antibiotics are necessary, and they're not needed for routine injections, radiographs, orthodontic or prosthodontic appliances, adjustment of those things, shedding baby teeth, and bleeding from trauma on the lips or oral mucosa, not needed. It may be reasonable to use them in certain cases of prosthetic heart valves, previous infective endocarditis, that makes sense, somebody who's been at risk, certain cases of congenital heart disease, okay, somebody who's had a repaired congenital condition, and cardiac transplant patients, okay, who develop cardiac valvopathy. So not even everyone that's had a cardiac transplant, isn't that wild, okay? So they would have to be, medically supervised and treated for the right reasons. None is necessary except for the conditions that I just listed. If someone has a mitral valve prolapse, not needed. Yes, Lila.
Also, is it the fact that the prosthetic replacement, for even for the valve, is it a matter of 6 months, right? If it passes 6 months and doesn't have a problem,
not necessarily. You're probably thinking of joints.
Joints, yeah.
Yeah.
Right?
So no, we're talking about prosthetic heart valve at this point.
But the joints,
we're going to cover that.
Okay.
Yeah, we're going to cover that. Okay. And it really depends on the person and the situation. Okay. But if somebody reports to you that they had rheumatic heart disease, that they have a mitral valve prolapse with or without regurgitation, bicuspid valve disease, calcified aortic stenosis, congenital heart conditions, okay? No prophylaxis is necessary. The coverage would be if there were no allergies to penicillin or amoxicillin, 2 grams, so that's usually 4 pills that are 500 milligrams 1 hour before. Yep.
I just had a question. So under cardiac conditions, like
Yep.
the first one, prophylaxis reasonable. So those would be the reasons why you do it?
But you do take it.
Okay.
Yes. Yep.
Gotcha.
Yep. Okay. So someone who is allergic to penicillin or ampicillin, they would give them cephalexin or clindamycin. Usually clindamycin is the choice. Okay. And those would be the ones that, and these are just other indications or oral cephalosporin in adult and pediatric doses. Cephalosporin should not be used with an individual with a history of anaphylaxis. So all of these things are taken into consideration. But generally the doses are going to be 2 grams of amoxicillin an hour before. That's generally how it goes. Allergic to that, usually clindamycin, and cephalexin is the other drug. The prosthetic joint prophylaxis, it's going back and forth so many times it like spins our heads most of the time, okay? And it really should be a conversation. It should not be routine that someone has had this replaced within a certain period of time. Yes, they take a drug. No, they don't take a drug. It was previously recommended that anyone that had a joint replacement within 2 years be covered. And so a lot of people were covered maybe that shouldn't have been. This really needs to be determined by their physician and their orthopedist. And sometimes you wind up having to call both of them to get a darn decision. Sometimes it's like, guys, I'm a dental hygienist. I know about this, but I'm not going to make this decision. Would you please make a decision for our common patient here? Okay, sometimes we have to assert ourselves a little bit. It should be determined by them. A medical consult is recommended. Sometimes they will get annoyed at you for calling, but you need to persist and do the right thing anyway. And it really depends upon the individual patient and if they have comorbidities such as diabetes, such as being immunocompromised, okay? And if there are other non-cardiac reasons for doing it and you're not sure, consult the physician, okay? We are better safe than sorry, but sometimes better safe meant that people were covered with antibiotics that didn't need to be, okay? Is this consistent with what you've heard before?
Yeah.
Good, okay, we don't want any confusion with that. We're actually done with this. We're gonna take our